Good morning, everybody. Welcome to Pediatric Grand Rounds. And now I have the opportunity to introduce our three wonderful speakers. First, I'll introduce Dr. Caitlin Murray, who is an assistant professor and a pediatric psychologist in the Department of Anesthesiology and Pain Medicine at Seattle Children's Hospital. She provides clinical services in the Pain Management Clinic at Seattle Children's, and her research focuses on the unique health and developmental issues facing young adults with chronic painful conditions, with the long-term goal of creating tailored interventions that target outcomes of highest importance to this population. Next, I will introduce Dr. Angela Hernandez, who is an assistant clinical professor in the Department of OB/GYN at the University of Washington. She practices pediatric and adolescent gynecology here at Seattle Children's. Dr. Hernandez is passionate about multidisciplinary care. She launched the Chronic Pelvic Pain Clinic in July of 2022 and also participates in the Reconstructive Pelvic Medicine and Differences of Sexual Development multidisciplinary clinics. And finally, Dr. Siwan Tham is an assistant professor in the Department of Anesthesiology and Pain Medicine at the University of Washington School of Medicine. She's a pediatric anesthesiologist and pain physician and provides clinical service as an anesthesiologist and multidisciplinary pain management clinic at Seattle Children's Hospital. Her research focuses on sleep disturbances and autonomic function in children and adolescents with chronic abdominal pain. Thanks so much to the three of you for being here. I will stop talking and turn it over to you. Thanks so much.
All right, well, thank you for having us. We are really excited to talk to you about the power of collaboration and how we treat chronic pelvic pain in our adolescent patients. We have no disclosures. I'd like to take a moment to acknowledge the land that we're on, and also to acknowledge that while we will be using gendered wording in this talk to refer to typical anatomy and development, we do recognize that there are many differences in both sexual development and gender identity. Today, our objectives are to discuss the etiology of chronic pelvic pain, to demonstrate how to apply the biopsychosocial model of pain to chronic pelvic pain, and to discuss our interdisciplinary approach to this treatment. So to start, what is chronic pelvic pain? Chronic pelvic pain is pelvic pain for 3 or more months. It is highly prevalent, with 1 in 7 women in the United States suffering from pelvic pain, but the prevalence in the adolescent population is truly unknown. Individually, women with chronic pelvic pain have higher rates of comorbid disease and also a higher use of medication. And on a societal level, it's quite costly, estimated to be about $2.8 billion per year, breaking down to about $20,000 per woman a year. Chronic pelvic pain impacts the individual in several realms, but it can also affect their parents and family. What is the relationship between pelvic pain and chronic pain? Well, dysmenorrhea, or painful periods, affects about 70 to 90% of adolescent females and is a leading cause of school absenteeism. In fact, it's the most common reason why a patient would be referred to see a pediatric and adolescent gynecologist. So if you're treating somebody with chronic pain conditions, it would be important to ask a little bit about their periods, because these patients would be at higher risk for suffering from severe menstrual pain as well. We also know that many pain conditions can get worse during the time of periods. So things just like migraines, even like dislocations and Ehlers-Danlos, headaches, IBS, all of those things can get worse during the menstrual cycle. So it would be important to treat and prevent childhood pain to potentially help alter the lifelong trajectory of pain in adulthood. There are many problems in the diagnosis and management of chronic pelvic pain. First, many of the symptoms are nonspecific. For example, I often have patients telling me that they have ovarian pain as they point to their umbilicus. And then they say that, the pain can sometimes migrate higher, maybe when they eat spicy food. And then they feel rectal pain, and then they have diarrhea, but only after they exercise a really long time, after they hadn't worked out in a while. So, what are we supposed to do with symptoms like that? And really, because of gender and racial stereotypes, pelvic pain is normalized in women. Women are often told periods are supposed to hurt, and a lot of these patients feel like they're told that the pain is in their head. They tell me things like they were told that the pain is just due to their stress, their anxiety, or it's just constipation. Current treatments only address the peripheral causes, and there's truly some barriers to getting some of those treatments with insurance, pre-authorizations, age restrictions. And really kind of one of the biggest things that we all face as physicians is just having that conversation with the patients about the treatments. There's a big kind of movement in this perception about medications, especially medications in gynecology, just masking the disease. There's a huge fear of side effects, a lot of concerns about long-term fertility, and those really are hard conversations even for me as a gynecologist. So if you're faced with those things in your practice, it's really okay to say, I don't really know. Let me refer you to somebody who can talk about that in a little bit more detail. From a clinician standpoint, patients with chronic pelvic pain can be very challenging. We have limited training on managing chronic pain, and these patients really are complex. We truly don't have enough time to go through and review all the ER visits, all the specialty assessments, all the imaging studies, and then after spending time and talking to them, answering the MyChart messages, collaborating with other physicians, writing school notes. Many of these patients sometimes just ask for a medication. They would like some oxy to help with their pain, and honestly, some people might just give it to them. There's a lack of multidisciplinary resources. In fact, I think the wait for the pain clinic at Children's is somewhere between 18 and 24 months. So what does this lead to? A delay in diagnosis, patient and family frustration with the medical system, and frankly, some provider frustration with the patient. Plus, there's a huge utilization of healthcare. So I hope by now that you can see that pelvic pain is complex. Unfortunately, chronic pelvic pain is often treated as a peripherally mediated condition, meaning is chronic pelvic pain the symptom or is it the disease? This goes back to that concept of the treatment that we offer masking the disease, and patients really just wanting to know, so what is it exactly that's causing this? Unfortunately, it's not always one answer.
So pain is a biopsychosocial phenomena. It is a multidimensional dynamic interaction between the biological, psychological, and social factors that really influence each other and result in chronic pain syndromes. This model shifts the emphasis on the exclusive reliance on the pathophysiology involved in nociception to the involvement of the patient's cognitive, emotional state, psychological vulnerabilities, and the conditioned responses to pain that can influence their pain responses and behaviors and experiences. So from this perspective, we have the assessment and diagnosis, prognosis, and consequently the treatment of the patient with chronic pain that requires a broad strategy that incorporates a wide range of biological, psychosocial, and behavioral factors in addition to, but not the exclusion of biomedical ones. Our pelvic pain clinic is interdisciplinary. We have our pediatric gynecologist, pain physician, pediatric psychologist, and clinic nurses who embrace the biopsychosocial model. We also include physical and occupational therapists with pain expertise and social work services if indicated. In our initial evaluation, so our first encounter with the patient, it includes a really comprehensive assessment that lasts about 3 hours. First, we see the patient and family as a team, followed by individual assessments. Once we have gathered all the information from the patient and family, we have an interdisciplinary case discussion. This is followed by patient and family feedback and treatment planning. I want to take a moment to provide some definitions. These terms are used often. Multimodal, as defined by the International Association for the Study of Pain, is the concurrent use of separate therapeutic interventions with different mechanisms of action within one discipline, aimed at different pain mechanisms. So a good example is a child with post-operative pain. He or she may have a peripheral nerve block and the use of a non-steroidal anti-inflammatory agent to help manage post-operative pain. Multidisciplinary is multimodal treatment provided by practitioners from different disciplines. And interdisciplinary is multimodal treatment provided by a multidisciplinary team who are collaborating in the assessment and treatment using a shared biopsychosocial model and goals. So our approach is truly interdisciplinary. During the initial evaluation, where the entire team is in the room with the patient and family, we have a number of goals. The first is we validate the experience of pain. A lot of times, these families have been to many, many different medical experts and sometimes feel that their pain is unheard or disbelief about their pain. It is an opportunity for us to learn about their perspectives, concerns, and for us to elicit from them what their goals are for us. We also use this as an opportunity to really develop a therapeutic relationship because it enhances engagement in our proposed treatment plan. There are a couple of elements in the history taking that should not be undervalued. This is an opportunity for families to really provide a narrative to tell the story about the evolution of pain and the impact on the child and the family. We investigate the patient and family's understanding of what is causing the pain. Often they may have worries that we don't know about, such as a family history of cancer, that they fear, but do not feel comfortable bringing it up unless asked directly. We want to also identify other pain conditions. Patients with chronic pain often do not usually have only one isolated area of pain. And understand the context of other medical diagnoses and potential bidirectional relationships and impact. This is also an opportunity to evaluate not just the patients, but the family's experience of treatment, trials, and efficacy. Specifically in this area, mother, grandmother, aunts' experiences of pelvic pain and the treatments they've tried.
Okay. So these are the things I focus on when doing my part of the evaluation. From a history, I get a detailed menstrual history. I ask questions like, how old were you when you had your first period? Did pain start immediately or maybe like a year into menstruating? When does the pain start? Does it start a few days before you actually start bleeding and last throughout? Do you have mid-cycle pain? All of these kind of give me clues about what I need to target in my treatment plan. I also get a history on what medications they've tried. If they've tried hormonal medications, what have they tried? For how long did you try it? And what was your reason for discontinuing it? We talk about past pelvic and abdominal surgeries and also get a detailed family history on conditions like endometriosis, any gynecologic complaints that the family might suffer from, breast and ovarian cancers, because again, what they're coming from helps shape some of their fears, their hesitations about treatment. I take a very thorough review of systems. I am trying to assess for their baseline. I usually tell them when we're talking about medications that my goal is to make their life better and not worse. So I want to know the things that they're already struggling with. Things like constipation, as you all know, most patients don't admit to constipation. What they might consider normal bowel movements might look like a weekly Bristol 2 stool. Constipation can definitely contribute to pelvic pain. It might not be the only thing causing the pelvic pain, but from a surgical perspective, if I am moving towards surgery, severe constipation hinders my ability to do a good evaluation for endometriosis. So I start talking about it and working on it from an early point and get help when needed. I'm also assessing for contraindications to estrogen, other medical treatments like Depo-Provera, and also looking into other comorbidities like acne, mood, hirsutism, things that might benefit in addition to the pain when we're talking about other medications. If patients are sexually active, I ask them if they're having pain with sex. Is it on initial penetration or with deep penetration? Do they have pain with orgasm? If these sorts of questions are uncomfortable for some of you to ask, don't worry, I ask these all the time. The patients get super red, and I just reassure them that, this is what I do with all my patients. Most of my exam really is just talking. It's, again, very different from your experience at an adult gynecologist. When I'm talking to my patient, they are fully dressed and sitting across from me. We're talking, and then if an exam is indicated, I step out and have them undress. Most of what we do can be accomplished with just an external GU exam. And that looks a little something like this, where I have the patient, I cover their top. They're not just completely exposed like that. But, it can be accomplished with this where they're sitting in a frog-leg position and using some gentle downward labial traction, I get a good look at the external genitalia. In terms of a workup, things like an ultrasound, a transabdominal pelvic ultrasound, not a transvaginal, can be used to rule out structural reasons. And again, if sexual activity is reported, then something like STI testing can be done. This is the differential diagnosis from a gynecologic standpoint that I'm thinking about. So just for some definitions, dysmenorrhea, painful periods, Mittelschmerz, the fancy word for saying ovulatory pain. Ovarian cysts, we'll talk a little bit about this later, but there are both physiologic and non-physiologic cysts. Endometriosis, very hot in the media right now, and again, we'll talk about this a little bit later. Things like pelvic congestion syndrome or Müllerian anomalies might be called out on some imaging. And then other conditions like PID, TOAs, or adhesive disease can contribute to a gynecologic source of pain. But like we talked about, it's not always just one clear-cut gynecologic diagnosis, especially in chronic pain patients. So this is why it's really important to take a thorough review of systems and address other sources of pain to help really kind of treat anything that could be contributing to it. So, one example I have is a patient who might be sent to me for, dysmenorrhea leading to school absenteeism. But at the same time, when you're doing your family history, they have a pretty significant history of IBD. And then again, doing the review of systems, notice that she's had a significant weight loss over the past couple of months, some fevers, some night sweats, and reporting mucus-coated stools. That's not to say she can't have endometriosis. That's not to say I can't give her medication to prevent ovarian cysts or her periods, but she should also probably see GI.
So now that my colleague, Dr. Hernandez, has conducted a very comprehensive exam looking for the potential etiologies of pelvic pain, I target my exam on a couple of different domains. Assessment of physical functioning, looking for elements that are suggestive of peripheral and central sensitization, and evaluation of etiologies of other pain syndromes. Patients who have chronic pain often suffer from a reduction in their physical functioning. So they can have altered biomechanical movements, they can have lower physical endurance. So a functional examination in a dynamic setting is most valuable. We can sometimes do that in our exam room, in the corridor hallways. I often ask for the help of my physical therapist and occupational therapist to provide a comprehensive evaluation so we can really look for deficits that are specific in their day-to-day activities. In my physical exam, I also look for these elements that we use as a proxy to determine do they have centralized pain. So allodynia, which is painful sensations that occur in the setting of a non-noxious stimuli, so like a cotton tip, and hyperalgesia, which is increased pain in the setting of a painful stimuli, such as a pinprick during examination, is often surprising to the families and the patient when I perform these examinations, and on their abdominal region, they have allodynia and hyperalgesia. And it's really helpful for patients and families because they then realize, oh, there are other causes, such as neurological changes, that have resulted in this pain. It has been increasingly recognized that chronic pain in one location often does not occur in isolation. So the term chronic overlapping pain syndrome or pain conditions have been recognized by the National Institutes of Health. It includes, but not exclusive of, these 10 conditions: TMJ disorder, fibromyalgia, irritable bowel syndrome, vulvodynia, chronic fatigue syndrome, painful bladder syndrome, endometriosis, headache, migraines, and low back pain. That we should really be approaching the patient from the lens of chronic pain diagnosis. During this time, I also evaluate for other medical conditions that may have any interplay and relationships with their pain experiences. So, looking for underlying mechanisms. It can be broadly classify into 3 groups: nociceptive, which is pain from activity in neural pathways that is due to an actual stimuli or a stimuli that may potentially damage tissue; neuropathic, damage or disease affecting the somatosensory nervous system; nociplastic, pain from abnormal processing of pain signals without clear evidence of tissue damage or discrete pathology involving the somatosensory system. Out of curiosity, how many folks in the room have heard of the term nociplastic? Thank you. I am very excited because I get to share this little nugget. So nociplastic pain was introduced in 2016. It was a term created to describe a mechanism distinct from nociceptive and neuropathic pain. Defined by the IASP, pain that arises from altered nociception despite no clear evidence of actual or threatened tissue damage causing the activation of peripheral nociceptors, or evidence for disease or lesion of the somatosensory system causing pain. Now, I'll go back to the definition in a little bit. The idea behind this is the underlying mechanism is that it involves augmented sensory processing, so central sensitization, peripheral sensitization, and diminished inhibitory pathways. Again, I'll go into those a little bit more. Now, this mechanism is assigned to what is previously termed functional pain syndrome, such as fibromyalgia, IBS, nonspecific back pain. It has been embraced by some proportion of the pain world because we were struggling for a really long time. There is nociceptive pain and there's neuropathic pain, but there is really nothing in between to help us give a diagnosis to patients. So really, they put the 2 words together, noci and plastic, okay? It unfortunately is a little bit controversial, and for reasons I'm sure you have picked up on. The definition really took what it is not. It is not nociceptive, so no clear evidence of actual or threatened tissue damage, and not neuropathic pain, which is really quite unsatisfactory. So the skepticism from a proportion of the pain world is that, well, it doesn't really make sense because if the idea is to have this umbrella mechanism that covers all the chronic pain syndromes, and there is no nociceptive process that's involved in this diagnosis, it doesn't apply to specific conditions such as irritable bowel syndrome, where patients would tell us it started off with, for example, a GI infection. It also is not satisfactory for conditions such as, chronic widespread pain, fibromyalgia, because there was no initial nociceptive event. For those who have embraced this term, there's another element to this. In the latest revision of the International Classification of Diseases, the 11th revision, we now have a chronic pain diagnosis. So there is now a code for chronic pain with chronic primary pain, chronic secondary pain. This is the first time on a large scale epidemiology level we will be able to collect data on chronic pain diagnoses. So what I have to say is that it is complicated. We are struggling with these growing pains. As we continue to understand more about chronic pain diagnosis, I suspect there will be an evolution in terminology and how we categorize chronic primary pain. What I can say is that it's important to keep in mind that pain may not fall neatly into one etiology. So it may not only be nociceptive versus neuropathic, but really there are multiple and mixed pain phenotypes. And pain may also present as a continuum. So a classic example is post-surgical pain. It may start off with a nociceptive etiology, but after 2 to 3 months, when pain is persistent, we would expect that there are elements of nociplastic pain in play.
So I am a pediatric pain psychologist on this lovely team, and as you may understand or may have gotten the hint, pain is very complex. We really try to have a whole understanding of our patients when they come in, and we even start with saying that we know that pain is complex and that there are many different causes and contributions that could be in play, and the impact has had a really multifaceted impact on their life as well. So my role as a psychologist is really to try to, is really threefold. I try to first get some additional pain history if we haven't gotten to this when we all kind of first meet together with the family, and really understanding kind of the context of when pain began, and whether there were life stressors or transition from middle to high school, for example, or just kind of family stressors occurring at the same time that may be contributing to the onset or persistence of pain. And that is sometimes true and sometimes not, but that can be really helpful in understanding our patients. I also try to get an understanding, and I think Dr. Tham and Dr. Hernandez do this as well, is just the consequences of pain on their life and the impact. So, and I'll talk a little bit more about that. And then a lot of my evaluation really is trying to understand and identify psychosocial factors that may be contributing. So risk factors that we kind of know from the literature that could be related to the onset or just persistence of pain, and that may be impacting their daily experience. And so I'll talk a little bit about that as well. When I assess for the impact of pain, I ask a couple of different questions, because one doesn't always suffice generally, but basically we want to understand a little bit more about the impact that pain has on their day-to-day life, and this can be in multiple different domains, and sometimes actually just asking them to take me through their typical day when in pain can be really important. That gives me a good picture of if they're in bed for most of the time resting in pain, if they're missing a lot of school, if they're using lots of screen time, and what the consequences are when they are staying at home, if they're isolated from peers, and sometimes even some family dynamics that can get to. So it's a good question to ask usually. And then what they would do if their pain was lessened. And I think this kind of gets to some of the activities that valued activities they used to engage in. It's not always school. Sometimes it is, but it's not always school. And sometimes that can be just hobbies and sports that they actually really feel some grief and loss over not doing. And that can be important for my goal setting and my treatment plan as well. So when we're assessing for the impact of pain, there's lots of different, there's lots of research on these different domains of life. Really, pain has a huge impact on the child and the family. And we have to understand and try to gather that information as much as we can. Usually this is not just one visit. And really we try to understand whether or not they have some sleep disturbances. Pain often affects sleep. There's a really high prevalence of sleep issues in this population, so trying to understand some potential insomnia, difficulties falling asleep and staying asleep. I think upwards of 80% of these kids usually have sleep issues, so this is an important one. And trying to understand too if they have some difficulties with school and their social life. So this could be, kids have troubles with concentrating on their schoolwork, completing their schoolwork, and they miss school. And sometimes resulting from that are also isolated from their peers and not really engaging with their peers, which is an important part of this stage of development. So it's actually pretty important to talk about as well. And then in general, activity, often their mobility is pretty low and they are not physically active. There's some fear around movement in this. In some of these patients, or there's kind of the opposite of that, which is pushing themselves too hard, leading to more pain sometimes. So it's important to kind of talk about activities and how that kind of plays out in their day-to-day life. And we also know that these kids are very, very at risk for developing depression, anxiety, and often can have pre-morbid or kind of before pain began, they can have some pre-existing anxiety and depressive symptoms. We've gotten pretty good at understanding some risk factors involved with the development of chronic pain in childhood and into adulthood. One of these factors is having some experiences with childhood trauma. And this doesn't have to be kind of the big T trauma that we think about always, but is a really important one to ask about, such as abuse and neglect. And this can be emotional, physical, and sexual abuse, and emotional and physical neglect, and also just kind of some general household challenges that are contributing to some chronic stress, and that might be traumatic experiences for these kids as well. That can be parent conflict, domestic violence, parent mental health or physical health issues, and parental substance abuse, and these things are important to kind of understand, but I might not ask all of these questions all at once. I might have to, their kids are like onions, so they kind of eventually, they'll peel away the layers, but, and then there's other important kind of like smaller T trauma stressors that I like to ask about. Often these kids have a lot of history with peer victimization. They often feel isolated from their peers, and they've also experienced a lot of invalidation from their friends about friends not really believing their pain exists, as well as their family members sometimes, unfortunately. And also, just their experiences with kind of repeated medical visits and medical trauma that can happen from that. So just undergoing lots of diagnostic tests, lots of uncertainty about what's going on, and really that fear of not knowing what's happening can be pretty traumatic in and of itself. In terms of mental health conditions, this is, again, really prevalent in this population. So a lot of kids have post-traumatic stress or even PTSD, a full diagnosis, or general anxiety disorders or social anxiety, just all sorts of anxiety disorders are really predominant. They also often have mood and depressive disorders, and they can, because often these kids are teenagers, they can have normal developmental experimentation with substances and have the added risk of, when they're having pain and some mood issues potentially and some sleep issues, that they are using substances to cope with those things without having any other treatments that have been working well, and kind of not really knowing what else to do, essentially. And then again, sleep deficiency is a really important thing to kind of talk about or assess for, that often these kids have developmentally, teenagers don't sleep very well. They're waking up really early, biological clock is later, and if you also have pain and all these other comorbid issues, we often see that they have really poor sleep quality, insomnia symptoms, and then even like reverse chronotype sometimes, where they're sleeping mostly during the day and not at nighttime. So there's lots of sleep issues that we like to talk about and assess for. And just in general, with kind of understanding kind of these not necessarily full-blown mood or psychological disorders, but understanding these other psychological factors that can really drive or be triggers for pain onset and maintenance is, again, I kind of talked a little bit about this, the uncertainty of the etiology of their pain and not understanding what's happening, being through a lot of doctors and sometimes hearing different things from different medical professionals, because that would be understandable as well, but also a very hard experience for our families. And having fear of pain is a big one too. Often there's this really kind of negative pattern of thoughts that can occur with these kids, again, understandably, because they start to feel a lot of fear with movement. It hurts to move. And there's some fear about potentially having an underlying injury. Do I have something going on? Is it okay and safe to move? So that is kind of deriving some of these kind of resulting avoidance behaviors, avoidance of kind of being active or going out with friends or going to school. And we also see a lot of kind of personality traits, I'd say. And again, I think of personality traits as not necessarily static, but very fluid. Some of these kids are very high in perfectionism, and that can, and even like people pleasing, high conscientiousness, and that can actually serve to kind of impede their progress and rehabilitation down the line. So I sometimes like to pick up on these factors early on. And then in general, when we are talking about kind of these like negative thought patterns that happen around pain, often we see lots of rumination and preoccupation with pain, feeling that the pain will never end, and kind of persistent worry about pain, as well as just a feeling of almost despair and helplessness that they will ever be able to improve because of how long they've been in pain. A lot of these kids have been in pain for several years when they come to see us. So imagine having a mindset where you're been through lots of different treatment options and don't really know what's happening, and that would be a very understandable kind of thing that happens as a result. So these are some of the things I like to talk about as well. And then I also, of course, kids come in with their parents, and parents are actually a really important part of both assessment and treatment planning. Parents are often really, I don't think I've met a parent who is not trying really hard to help their kid with pain. And it is a very distressing experience to see your kid in so much pain and not to be able to do anything. So there's a really high level of parent distress that can happen. Often they worry a lot about kind of how ineffective treatments have been, not being able to feel like they're helping at all, feeling hopeless about that, and almost kind of feeling some self-blame for not being able to help them. And there's also, again, all parents are trying to help their children, and so this is never intentional. But sometimes parents also have responded to their child's pain with things that might be more maladaptive or not kind of helping them improve in the long run. And that's things like, having sort of protective behavior, like letting them stay home from school or kind of not, engage in chores and things like that when they're in pain, which can actually serve to, just make their pain worse and kind of turn up the signaling of pain, but also really kind of, show some decrements in functioning. And then pain is very expensive as well, as we kind of talked about before. Often parents are missing work because of taking kids to treatments, and often we'll see a very high financial burden and sometimes just overall socioeconomic stressors that I like to talk about as well. So, and I think this quote is kind of something really kind of wraps up this general kind of experience I have with when I talk to parents that they're, and it says, "I find myself giving up more of my life to meet my child's needs than I ever expected." So there's a lot going on with these kids and their families.
So after our initial evaluation across our different areas, we meet to have a case discussion of our findings. During this time, if we felt that there are other investigations that are needed, such as labs or imaging studies, we send the patients to main campus to have these conducted if possible. Throughout the entirety of our evaluation process so far, we have incorporated elements of pain education. It began with asking about their current understanding of pain and possible biomedical causes and previous medical examinations. In our pain education specifically, there are 7 key learning objectives, and we'll go through some of those in a little bit more detail in the subsequent slides. But really, pain is a protector. The pain system can become overprotective. Pain is really a brain output. It is not an accurate marker of tissue state. There are many potential contributors to one's pain. We are bioplastic, and pain education itself is treatment, and there's strong evidence to show the efficacy of pain education. We have seen this very renowned picture by Descartes when a potentially painful stimulus activates a peripheral nerve, which is transmitted to the spinal cord in the brain and alerts the organism to threats and injury. So we are all very familiar with the concept that pain equates danger. But additionally, we also generally believe that there's a linear relationship between an identifiable organic pathology and patient-reported symptoms. So if the pain is minimal, the pathology is small. And if the pain is severe, the pathology must be deadly. So this is what acute pain, the experience that we're most familiar with, is commonly likened to. However, we now know that chronic pain is complex. It involves reorganization of many parts of the central nervous system. So starting from the periphery, an organ injury can result in local changes that lead to peripheral sensitization. Then there's changes in the spinal cord we term central sensitization. This leads upwards to anatomical and functional reorganization at the cortical level. So from imaging studies, we know that brains of folks with chronic pain are different to brains of those who do not have chronic pain. And in all of this, these chemical, structural, and functional changes lead to this persistent heightened state of neuroactivity and chronic, widespread, and migratory pain in the absence of sensory stimuli. Now, this is all quite challenging if you were to explain this to the patients and family. So we use a lot of metaphors and analogies in our work to help patients and families understand what central pain is. Chronic pain is like a car alarm. Some car alarms are very sensitive, can go off when it is gently bumped, while others hardly go off at all. The purpose of the car alarm is to alert that the car is in danger. However, when the alarm goes off accidentally and there's no sign of danger, it is a false alarm. Cars with sensitive alarms send out more false alarms, and people with more sensitive nervous systems can have more false alarms as well. There's also other mechanisms involved in the chronic pain development, and another is the dysregulation in the descending pain modulation systems. These descending pain circuits arise in the brainstem that can facilitate or inhibit pain chronification. So the periaqueductal gray receives input from higher brain centers and is capable of activating analgesic effects. There's a lot of studies looking into placebo effects, and it is the thought that these processes are involved in placebo effects. The rostroventral-medial medulla can act as a final relay in the control of descending pain facilitation. And these structures interact with the cortical and subcortical sites to influence the risk of pain chronification. So it speaks to the behavioral and cognitive process that can influence descending modulation and therefore pain experiences. Again, a lot of words. Another analogy that we use, you can think of pain like trying to fall asleep in an old house. If you listen quietly, an old house will creak and groan at night. If these sounds are familiar because they happen all the time, you assume they're normal. You do not pay attention to them and drift off to sleep. However, if someone had broken into the house recently, you would be on high alert. You would pay close attention to every creak and groan and wonder if someone was trying to break in again. Stay awake for hours. So, if you pay attention to your pain, you may find that it is not as difficult to do what you want. Sorry, typo there. If you don't pay attention to your pain, you may find that it's not as difficult to do what you want to do. But if you think a lot about what your pain might mean or how much the pain is bothering you, you will find that pain interferes more with your life. We talk to patients and families about neuroplasticity. Adolescence is really a period of heightened plasticity. It is characterized by really intense structural remodeling and neuroreconfiguration of these higher cognitive centers in response to internal and external stimuli. On one hand, it can present as a vulnerability because we know that rates of anxiety and depression are elevated during adolescence. However, on the flip side is this opportunity for intense learning. And our treatment for chronic pain can leverage on this heightened plasticity in order to improve outcomes. We have really good evidence. A systematic review looking at all the intensive pain rehabilitation programs show that there are large improvements in disability, so physical functioning, and small to moderate improvements in pain intensity in programs that range from 1 to 4 weeks. When we look at longitudinal studies of individuals with childhood pain into young adulthood, now keep in mind, this is not a large body of work at all, but we do know that up to 65% have resolution of childhood pain during their young adulthood. So we present a more optimistic view of the trajectory of chronic pain in the pediatric population as opposed to, the media coverage of chronic pain in the adult world. We present our treatment plan. Physical functioning is a core tenet that we focus on. We provide education to facilitate an increase in the physical functioning, with the emphasis that we cannot wait for pain to go away before resuming function, because pain is supposed to be a protective mechanism. It will not go away unless we start moving. And the emphasis is on function as opposed for waiting for pain to get lessened. And when there is pain, it does not indicate harm. It is a signaling issue. So we use different strategies because words sometimes are not completely effective. The key is to set some expectations. The goal is to resume normal activities and really trying to tailor it to the adolescent goals. No adolescent, well, apart from perhaps teenage boys, want to go to the gym. 5 days a week, an hour a day. Okay, so it might be soccer, it might be trampoline, it might be going out to play with their friends, shopping. So you start with, okay, go shopping, 10 minutes a day, every single day, but it has to be tailored to what they have been doing. So if they haven't walked for weeks, that is not going to be achievable. So I start with 5 minutes in their home. But the key is no matter how much pain they feel, they have to be able to do it again the next day and to increase it by 1 to 2 minutes a week. So that's activity pacing. We also, because it's sometimes hard to do this by themselves or have parents do this, we enlist the help of our really skilled physical and occupational therapists to address the pacing and greater exposure, but also there are likely autobiomechanics, sensitivity of painful sites, and they can incorporate strategies such as desensitization. Medication management has to be undertaken with intention. We know this because there's really limited evidence of the efficacy of pharmacologic management in pediatric chronic pain conditions. There's a couple of principles that I adhere to in using medication is that we would like a single prescribing provider or team so that we have consistent messaging. Because we are a tertiary care clinic, I collaborate with primary care providers, pediatricians, so we have a shared care model. I also recognize that I'm limited in knowing the experiences of patients and families, and primary care physicians and pediatricians know the whole family. So I lean on them to understand not only their other medical diagnoses, but on the more frequent visits that they have with their primary care providers. And often I may have them prescribe on the consultation model, and it has worked well for me in the past. I usually only prescribe when the family has embraced this multidisciplinary approach and they're not reliant on only the biomedical model. And the education piece is this is a short-term bridge to facilitate the other treatment strategies. So increased participation in physical activity and PT. An example would be they tell me that they are too sore to go back to PT anymore. I may incorporate an NSAID during the PT session so that they can continue participation. Of course, we will select the agents to target the mechanisms of pain. I try to start with the lowest dose possible and as needed, if possible, versus schedule, but really targeting mechanisms.
All right. So for my portion of the GYN treatment plan, I'm again educating and reassuring the patients and their families, letting them know what's normal, what's not normal, doing a lot of destigmatization of gynecologic issues. I like to provide them with medical based resources over like what they're just seeing on TikTok or hearing from their friends. And I also reiterate that whatever your mom, your friend, your neighbor might have experienced on certain medications or with their conditions could be completely different from yours. From a medication standpoint, we're talking about mainly hormonal medications containing estrogen and progesterone, which I'll talk about a little bit later, and non-hormonal medications. But I do reiterate over and over and over again that everything is going to have side effects. Nothing is 100% effective or immediately effective. From a surgical standpoint, most of chronic pain is going to have more of a diagnostic surgery. Surgery tends to play a bigger role in our acute pain, ovarian cysts, torsions, hematocolpos, but still is part of our conversation. And in terms of anticipatory guidance, dealing with both the family and the patient and their parents, there's a lot of questions about how is this condition going to affect her ability to get pregnant? Will it complicate pregnancy? Will she ever be able to be intimate with anyone? Questions like that. So I'd like to briefly just go over some of the common diagnoses and referrals that I see, just to give you an overview of my counseling. And regardless of what scenario you see these patients in, a lot of times just reiterating some of these messages can go a long way. So ovarian cysts. Just first and foremost, it is the ovary's job to make cysts. It is 100% normal to have cysts. If you scan the people in here who have ovaries, you will find ovarian cysts. That's not to say that these cysts can't be uncomfortable, but things like follicles, corpus luteum cysts, hemorrhagic cysts, completely normal and usually go away on their own without intervention. We can prevent them, but I think a lot of education is important around this, especially in the media and society. Ovarian cysts are just thrown around quite a bit. And if you need help with this conversation or just want to hand them something on their way out of the ER, we have a handout on child. Endometriosis is another condition that we're hearing a lot about. There is so much information about endometriosis on social media. There was a study a couple years ago that looked at, hashtag endometriosis, looking at both patients and providers talking about it, and they showed that more than 25% of them had misinformation. The themes of them were a huge distrust in providers and just basically a miserable life. So not the things that you want to be feeding to your patient or encouraging if it's unsure. Endometriosis affects 1 in 10 women. There's a huge delay in diagnosis, and patients who have a family history of this are much more likely to have it. I'd like to emphasize that laparoscopy or surgery is the only way to diagnose this condition. Imaging cannot diagnose endometriosis. There are some studies looking at the utility of MRI for this, but it is by no means the standard at this point. And lastly, there's no cure for this. So just sit a moment and think about that. There is no cure for endometriosis. And if, later on y'all want to just Google endometriosis and see what patients are reading online, if they were, somebody casually threw around, you might have endo, just try to get an idea of, the life that they're being pitched. For diagnostic laparoscopy, patients are often coming to us asking for the surgery to cure endometriosis, as told to them by social media, other providers, friends, etc. Again, surgery is diagnostic. We're taking a look around, and if we see endometriosis, we will excise or ablate that. If we don't see endometriosis, we take random biopsies in a place where we know it likes to hang out to hopefully get a diagnosis. If we see it, most adolescents have stage 1 to 2 endometriosis at the time of diagnosis, but really the main treatment is going to be medical management. When these patients have been suffering with pain for such a long time and really kind of putting all their eggs into that endometriosis basket, when I am pre-opping them, I always tell them, I'm happy to take a look around. I will remove what I can. Your treatment is still the same treatment regardless of whether I see it, but I try to mentally prepare them for the fact that I might not see endometriosis in there. Those biopsies might come back negative, but that doesn't mean that their pain isn't real, and that doesn't mean that you still can't go on the same medications that I'm about to talk about. So when we talk about treatment, the treatment for most gynecologic causes of pain are going to be hormones. This is another handout on child. Really, again, emphasizing that nothing is 100% effective, nothing works immediately. Please give it a grace period of 4 to 6 months, and that everything is going to have side effects. One of the benefits of getting that diagnosis of endometriosis is that it opens up doors to endometriosis-specific medication. But otherwise, really, all of these things are offered to patients regardless of whether or not they get a scope and regardless of whether or not that, the diagnosis is made. I do just want to mention, the IUD or intrauterine device is the top one on that list. And while I do love that IUDs are being talked about in the community, I do want to caution the promotion of an IUD kind of being promised as this magic this this magic solution, because while it can help a lot of people, it is quite an uncomfortable procedure when done in office, and it might not be the best option for everyone. For example, in somebody with really severe anxiety, kind of comorbid IBS symptoms, a history of sexual abuse, perhaps having a device located in their uterus that in order to remove, I'd have to go through their vagina wouldn't be the best thing, especially if they haven't even tried pills yet. And this is the handout where that came from, also on child.
Okay, so in the interest of time, I'm going to kind of fly through some of this. I hope that's okay. Yeah, thanks. So when I meet with patients and I'm thinking about kind of their individual treatment, the majority of the time I'm going to be kind of picking and choosing what we'll be working on. But overall, the goal is to teach kids and their parents how to manage pain, and that's through thinking of learning new ways to think about their pain, and also changing their behaviors and kind of breaking the cycles that might be related to their pain as well. And when we think about, why do families need psychological therapy, predominantly I use cognitive behavioral therapy, but that can mean lots of different things. So just generally, we are doing this because recovery from pain it's not intuitive. It is a hard sell sometimes to tell kids to be more physically active when they're in lots of pain, and that will actually help them feel better. And likewise for parents and caregivers, it's hard to tell them that this intuitive kind of parent support of letting their child rest when they're sick is not actually helping their child. Again, as Dr. Tham was talking about, we want to teach them that pain hurts, but it's not harmful. So kind of reiterating that message throughout all specialties is really, really important. And that getting back to school, again, can help. Again, kids don't really love going back to school. It's usually pretty stressful. So it's honestly a very hard sell as well, but doing that early on can really help with their diagnostic process. And then, thinking about ways and changing ways that they think about their pain, and not preoccupying themselves with their pain, but also trying to change some belief systems around pain is really important. There are some common elements with psychological therapies. Often we're using relaxation and mindfulness to kind of decrease pain signaling, or really just turn down the dial of pain. And we're also doing some cognitive and behavioral strategies like pacing, as Dr. Tham was talking about, sleep interventions, almost to like reset their pain cycle. And so those strategies can be really helpful in getting them to feel better, honestly, especially with sleep and kind of mood interventions sometimes, and then that can help with their recovery process. When we're thinking about kind of specifically changing belief systems around pain, we've all been talking about this in lots of different ways, but from a psychology standpoint, we're really trying to shift them away from these black and white thoughts, such as I can only be happy when I'm in no pain, I can't do anything when I'm in this much pain, and shifting them towards something that's more in the middle, right? Black and white, and going to the gray areas. I can maybe, instead of not going to soccer practice at all or school at all, I can go to one class, or I can go to, just participate as like a record keeper in soccer practice. And we already talked a little bit about the importance of trying to help patients and their parents understand that their pain does not always mean harm, and trying to shift them away from that, and also focus on functioning despite being in pain, and that's going to actually improve their progress. And again, with some parent interventions, parents are a really important part of the process. Almost just as important as working with the child is working with the parents, I'm sure, as all of you may know. Really we try to get them to move the focus away from pain, so not like lots of questions during the day or check-ins about their pain, and having different consequences for pain days, and that's an operant strategy where, instead of being able to watch TV all day when they're at home, to be able to do some quiet activities and have different consequences for those days. And then modeling, sometimes parents often have pain themselves or other health issues that they're coping with, so them actually modeling good adaptive behaviors can be really helpful to teach them as well.
All right, just a few more slides. So primary care doctors and pediatricians are often the first line and the point people in managing chronic pain. So by presenting a multifactorial etiology and applying the principles of the biopsychosocial approach, patients can receive a uniform message and have improved experiences. Things as simple as encouraging good sleep, regular bowel movements, cognitive behavioral therapy. These are things that patients often need to hear from multiple sources before they have the buy-in for it. If you think you have a patient who would benefit from our approach, this is the order on Epic. It's just an ambulatory referral to gynecology and under clinic subspecialty selecting pelvic pain clinic. You can always just message me on Epic or start with a gynecologic referral if you think that's more appropriate. If a patient is looking for surgical intervention, it helps if you specify refer to a gynecologic MD in there. So in summary, I hope you all can understand that chronic pelvic pain is quite complex, multifactorial, and benefits from the biopsychosocial approach. The interdisciplinary approach really shifts from peripherally directed therapy and focuses on function and disability. And again, unlike in adult populations, pain rehab in our population can be successful. Here are some resources, and thank you.